You're listening to Who Said, a Cardiology board review series. No fluff, just facts.
This episode is about patent foramen ovale. We'll go over the presentation, physiology, imaging features, and management, including intervention. A patent foramen ovale is not technically an atrial septal defect. They are two different things, and we'll go over the differences. What is a PFO? When the septum secundum finishes growing, a small opening with a flap called the foramen ovale remains. The foramen ovale is necessary because it provides a one-way, right-to-left passage for blood to pass to bypass the lungs in utero when the lungs are not yet functioning. Upon birth, when the pressures in the pulmonary vasculature drops and the pressure in the left atrium exceeds that of the right atrium, the foramen ovale will become sealed up within hours of birth in 75% of infants. In the 25% of people in whom the foramen ovale does not seal completely, a PFO will be present and will allow for right-to-left shunting whenever the RA pressure exceeds that of the LA, such as during a Valsalva maneuver. Most patients will never have any problems because unlike a secundum ASD, PFO does not result in left-to-right shunt and does not cause right heart enlargement, pulmonary hypertension, or atrial fibrillation. Presentation: platypnea-orthodeoxia syndrome, which is dyspnea and hypoxemia in the upright position that resolves when lying supine, can be from intracardiac shunt from PFO, ASD, or atrial septal aneurysm with fenestration, the most common etiology being patent foramen ovale, pulmonary conditions with ventilation perfusion mismatch such as interstitial lung disease, hepatopulmonary syndrome, or pulmonary arteriovenous malformations. These are the situations that can cause platypnea-orthodeoxia syndrome. The most common cause of platypnea-orthodeoxia syndrome overall is patent foramen ovale. In order for PFO to cause platypnea-orthodeoxia syndrome, there must be some condition that causes distortion of the interatrial septum while in the upright position, such as kyphoscoliosis, ascending aortic dilation, post-pneumectomy, or post-lung transplantation, or right hemidiaphragm paralysis. When evaluating platypnea-orthodeoxia syndrome, agitated or saline bubble study should be performed in both the supine and upright positions. Next, let's talk about imaging. What features on brain MRI suggest that the etiology of an ischemic stroke is cardioembolic, which could be PFO or AFib? Well, multiple infarcts in different vascular territories, large infarct size, or hemorrhagic transformation. Let's go over the multiple infarcts in different vascular territories. Cardioembolic strokes often result in emboli lodging in different arteries, leading to infarcts in different territories. For example, both the anterior and posterior circulation, or the bilateral hemispheres. This scattered pattern highly suggests a cardioembolic source. Large infarct size. Cardioembolic strokes are often large territorial infarcts involving the cortex and subcortical regions because emboli can obstruct large arteries, such as the middle cerebral artery. Hemorrhagic transformation. Cardioembolic strokes are more prone to hemorrhagic transformation, especially when large emboli occlude major arteries, causing ischemic damage that later bleeds when reperfused. This hemorrhagic transformation may be detected on follow-up imaging. How do you distinguish between ASD, atrial septal defect, and PFO, patent foramen ovale, on echo? In ASD, you will see dropout in echo, whereas in PFO, there is a flap, but the flap is open. PFO will not cause RV volume overload, unlike ASD. PFO occurs in 25 to 35% of the population. Closing PFO is only needed if there is cryptogenic stroke. The direction of flow across the PFO depends on the difference in pressure across the atria, so it is possible to see no shunt by bubble or contrast unless you tell the patient to do the Valsalva maneuver to bring out a right to left shunt. Compared with an ASD, PFO is more commonly associated with an atrial septal aneurysm, prominent eustachian valves, and Chiari network. In contrast, an ASD is more likely to be associated with right-sided enlargement due to left-to-right shunting than a PFO. In patients 18 to 60 years of age with a non-lacunous stroke and PFO, the following evaluation is recommended. MRI of the brain to confirm ischemic stroke, MRI or CT of the intra- and extracranial vessels with contrast, evaluation for deep venous thrombosis including lower extremity Doppler and consideration for pelvic MRV, prolonged, i.e. 30-day cardiac monitoring to assess for atrial fibrillation, echocardiography, and further evaluation depending on the clinical presentation, such as toxicology screening, C-reactive protein level, antiphospholipid antibodies, blood cultures, hypercoagulable evaluation, and vasculitis evaluation. These are the evaluations that are recommended in patients 18 to 60 years of age with a non-lacunar stroke and PFO. If this evaluation yields no alternative etiology for the ischemic stroke other than the PFO, then a potential paradoxical embolism is possible. The next step would be determine whether the PFO is high risk, in which case PFO closure is reasonable, or low risk, in which case PFO closure benefit is not well established. High-risk PFO would be a PFO with atrial septal aneurysm or large right-to-left shunt, meaning more than 20 bubbles. If there is atrial septal aneurysm or large right-to-left shunt through the PFO, PFO closure is reasonable unless there are factors reducing the potential benefit of closure, such as a low rope score, such as age and involving old age or multiple risk factors, and the need for anticoagulation. If there is no atrial septal aneurysm nor large right-to-left shunt through the PFO, PFO closure does not have a well-established benefit, so it shouldn't be done unless there are factors increasing the potential benefit of closure, such as a high rope score, for example, young, age, no risk factors, history of DVT or prothrombotic condition, prior non-lacunar stroke or cortical TIA, or failure of antiplatelet treatments. Management. Let's hear from the 2022 SKY guidelines for the management of patent foramen ovale. The SKY format is different from the ACC AHA format. Instead of categorizing the strength of a recommendation as class 1, 2A, or 2B here, the strength of a recommendation is expressed either as strong, i.e. the guideline panel recommends, or conditional, i.e. the guideline panel suggests. Strong means most individuals should receive the intervention or tests. Formal decision aids are not likely to be needed to help individual patients make decisions consistent with their values and preferences. Conditional means you should recognize that different choices will be appropriate for individual patients and that you must help each patient arrive at a management decision consistent with his or her values and preferences. Decision aids may be useful in helping individuals to make decisions consistent with their values and preferences. In patients who have not yet had a PFO-related stroke, who have conditions such as TIA, migraine, DVT, thrombophilia, atrial septal aneurysm, or scuba diving, they generally do not recommend PFO closure. Specifically, here are their statements. In persons with a history of transient ischemic attack and without prior PFO-associated stroke, the SKY guideline panel suggests against PFO closure. That's a conditional recommendation. In patients with thrombophilia and without prior PFO-associated stroke, the SKY guideline panel suggests against the use of PFO closure in addition to antithrombotic therapy, conditional. In persons with a history of deep venous thrombosis and without a prior PFO-associated stroke, the SKY guideline panel suggests against PFO closure, conditional. In persons experiencing migraines without a prior PFO-associated stroke, the SKY guideline panel suggests against routine use of PFO closure for the treatment of migraine, conditional. In persons with atrial septal aneurysm and without a prior PFO-associated stroke, the SKY guideline panel suggests against the use of PFO closure, conditional. Lastly, in scuba divers with prior decompression illness and without a prior PFO-associated stroke, the SKY guideline panel suggests against the routine use of PFO closure to prevent decompression illness, conditional. However, there are certain situations in which patients who have not yet had a PFO-related stroke can have PFO closure. In persons with systemic embolism and without a prior PFO-associated stroke in whom other embolic etiologies have been excluded, the SKY guideline panel suggests PFO closure rather than medical therapy alone. That's a conditional recommendation. In patients with platypnea-orthodeoxia syndrome and without a prior PFO-associated stroke in whom other causes of hypoxia have been excluded, the SKY guideline panel suggests PFO closure rather than no PFO closure, conditional. How about patients who have had a PFO-related stroke? In patients between the ages of 18 and 60 with a prior PFO-related stroke, the SKY guideline panel recommends PFO closure rather than antiplatelet therapy alone. That's a strong recommendation. In patients 60 years or older with a prior PFO-related stroke, the SKY guideline panel suggests PFO closure rather than long-term antiplatelet therapy alone. conditional. So it's the same thing, it's just a weaker recommendation in those over 60. In patients between the ages 18 and 60 with a prior PFO-associated stroke and no other indication for treatment with anticoagulation, the SKY guideline panel suggests PFO closure plus antiplatelet therapy rather than anticoagulation therapy alone, conditional. Same thing for those over 60. A rope score of at least 7 may identify patients who are likely to receive greater benefit from PFO closure. In patients with a history of atrial fibrillation who have had an ischemic stroke, the SKY guideline panel suggests against the routine use of PFO closure, i.e., if you have stroke and atrial fibrillation, you still need neurology to have some level of confidence that this etiology of the stroke is cardioembolic from the PFO before you can do PFO closure. The guideline also identifies 3 conditions where PFO closure should be added on top of lifelong anticoagulation. In patients with thrombophilia and a prior PFO-associated stroke, the SKY guideline panel suggests PFO closure in addition to lifelong anticoagulation therapy rather than anticoagulation therapy alone. That's a conditional recommendation. In patients with a history of DVT requiring lifelong anticoagulation and concomitant PFO-associated stroke, the SKY guideline panel suggests PFO closure plus lifelong anticoagulation rather than lifelong anticoagulation alone, conditional. In patients with a history of pulmonary embolism requiring lifelong anticoagulation and a concomitant PFO-associated stroke, the SKY guideline panel suggests PFO closure plus lifelong anticoagulation rather than lifelong anticoagulation alone, conditional. These are the official 2022 SKY guidelines that I just told you about, and they're quite broad. More recently, the Roundtable of Academia and Industry for Stroke Prevention, RAISE, put out a paper in Stroke in 2023 on patent foramen ovale management for secondary stroke prevention, calling for the use of the Pascal risk stratification system, which I find more practical. Using prospectively validated PFO-associated stroke causal likelihood risk stratification, or the Pascal risk system, patients can be classified into 3 subgroups based on 2 domains. Domain 1 is presence of high-risk PFO features defined as the presence of a large shunt, more than 20 to 30 bubbles depending on the trial, atrial septal aneurysm, midline or total shift, or both. And the second domain is the ROPE score, the risk of paradoxical embolism score, dichotomized into 7 to 10 versus 0 to 6. Higher ROPE scores, 7 to 10, indicate a larger attributable risk of stroke to PFO. Patients are classified in a 2x2 quadrant table. They're classified as probable if they have both a high-risk PFO and a ROPE score of at least 7. Probable patients have a 90% relative reduction in the recurrent ischemic stroke with closure. Patients are classified as possible in 2 scenarios, which are the 2 diagonal boxes. Either they have a high-risk PFO or a ROPE score of less than 7, or a low-risk PFO, meaning absence of a large shunt and atrial septal aneurysm, and a ROPE score of at least 7. Possible patients have a 62% relative reduction in recurrent ischemic stroke with closure. Patients are classified as unlikely if they have low-risk PFO and a ROPE score of less than 7. There is not a significant difference between closure versus medical therapy among patients in the unlikely category. PFO closure can be done in patients in any of the 3 quadrants except those in the unlikely quadrant, which has no high-risk PFO features and ROPE score less than 7. Now, I'll briefly touch upon other anatopic issues at the atrial septum. Atrial septal aneurysm, which occurs in 2 to 3% of the population, is a redundant and mobile atrial septal flap with a phasic excursion of more than 10 millimeters from the midline or a total of more than 15 millimeters regardless of distance from the midline during the cardiac cycle. 60% of interatrial septal aneurysm patients have a PFO, or less likely ASD. Chiari network is a meshwork of thread-like strands connecting the IVC and coronary sinus with the crista terminalis. It is due to failure of resorption of the right-sided sinus venosus valve. Chiari network does not cause flow obstruction. Normally, during fetal development, the Chiari network fenestrates to form the Tabesian valve, the valve of the coronary sinus, and the Eustachian valve, the valve of the IVC. Chiari network is present in 2 to 3% of normal hearts. That's all for patent foramen ovale and associated atrial septal issues.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.